Bona tarda i benvingudes i benvinguts a la conferència 40 anys de gestió comunitària de l'estrès. Què n'hem après? A càrrec de Molly Lejat. La conferència és organitzada per la secció d'emergències del COP. Abans de començar, us recordem que l'activitat tindrà una durada de 2 hores, amb una primera part de ponència i un espai final destinat al torn de preguntes, en el que podreu participar a través del xat. Us recordem també que aquesta conferència es realitza en anglès i que disposeu del servei de traducció simultània al català. Per escollir l'idioma haureu de clicar sobre l'opció Interpretació, que trobareu a la barra d'eines de Zoom, normalment a la part inferior de la pantalla. El Molly és psicòleg, Senior Medical Psychologist, expert en psicotrauma i director del Centre Internacional de Prevenció de l'Estrès, al Teihal College a Israel. També és fundador i director de l'Institut de Dramateràpia i autor d'un dels 3 programes de prevenció del suïcidi aprovats pel Servei de Psicologia Educativa del Ministeri Israelià d'Educació. Us informem que la sessió serà gravada i que l'organitzador prohibeix expressament el registre audiovisual i la posterior difusió o exhibició de la imatge en qualsevol suport, ja sigui material o electrònic. Així doncs, iniciem l'activitat. Quan vulguis, Molly, ja podem començar. Gràcies.
All right. So, good afternoon, everyone. I'm very pleased to be with you this time on Zoom. But as you remember, we have met several times in Barcelona in your offices. So this time we'll do it on Zoom. As was said before, I will be speaking for about an hour and a half, and there will be an opportunity to ask questions or to comment. And our focus will be community, and perhaps I will try to convince you that although most of us are clinicians, it is within community that I would say rehabilitation and recovery happens. And for various reasons, mostly I would say because of the numbers of people that are looking for help, mostly following COVID-19, it is very important for us to look into all the aspects of community and its ability to do some prevention and, of course, intervention work. Just to tell those of you who don't recognize these photos on the main screen, you see our center, which is this brown building. It's a rather nice building situated on a stream where you have opportunity to sit with the clients by the river and let them listen to the flowing waters. And sometimes we are playing with them guitar, so they will relax, mostly the very severe cases of PTSD. Some of them are even getting into the water, and these are very cold, or I say very cool water. So it's also helping in getting them less aroused. I would just follow the other picture is the only mountain with snow in Israel, and that's Mount Hermon. It's just outside on the hills that are surrounding our center. So I decided to show you a little bit of that, though we are so far away right now. So where are we? We are, as you can see, at the very north of Israel, in a town that is basically on the one side, it is with Lebanon, and the other side is with Syria. And that's probably what led us so many years ago already to look into prevention and resilience. Personally, I came to this town in 1979. I must admit I was a very young psychologist then. One way to understand it is to tell you that in those days I asked my hairdresser to put some black lines in my hair. Sorry, white lines in my hair. Nowadays I'm trying to ask him to color my hair black. So just to tell you what is the change in time. Anyway, I came to this town that was constantly under shelling from the Lebanese side. It is 1997, so not many years after a major conflict between Israel, Egypt, and Syria. And I found that people there are very well in running to the shelters. However, very few is done to their psychological or psychosocial aspects. And so I started to study what so many of you are already acquainted with, the resilience model that we have developed there, the basic PH. And that basically was one of the first, I think, studies that was done by asking the target audience and learning from them, and then making it into a model, rather than sitting in the academia and thinking what are the components of and how people are making it in times of crisis. So basically, this is where we are. And next, I would like to tell you that we have been in this area, as you see, said 35 years, but basically, I should have said to you when I sent it, is now 43 years. And our main mission is to promote the knowledge and practice of human resiliency in the framework of coping with stress and crisis, both for individual, organization, and national-wide. That means we're not only working with individual clients, we're working with families, we're working with groups, and even with ministries and national, international. I'll mention it very soon. It's just a quick introduction to who we are. So basically, as you can see, we've been established in 1980. So you can see we are 43 years old. And some years later, about 14 years later, we became an NGO, which in a way helped us to free ourselves from any, I would say, influence of any body, be it government or any, I would say, established institute. It has its downsides because you don't get a constant, I would say, resources from government, but at the same time, you are independent in the sense that you can work with any community, with any religion, with any color, both in Israel and outside. To date, we have over 50 staff members. Many of them are psychologists, social workers, school counselors, disaster management, and we also have a doctor on our team. So I can tell you that probably some of you have been to our training in Barcelona and in Madrid, but we have done so many thousands of hours of professional training. And just in the last years, we did a count, or I would say an estimation of how many training hours and how many face-to-face therapy we have, and you can see the numbers here. On the whole, if we're looking only at 2022, and now we have even more, we have 14,000 treatment hours face-to-face. That means we have about steady clientele of about 350 people that are coming on a weekly basis. We, of course, combining both the clinical work and the prevention work. And what is very important is that we also work with the normal population, that with the community. We don't only work with the individuals or families or groups that have been affected, such as in recent year, we had a horrible traffic accident with 3 young men died, and all of them have been were still in schools. So all these schools were very, I would say, critically affected on all what we call the circles of vulnerability. So the work was not only with the immediate family and relatives or friends, but with the circles around them, like the school system. And because some of them were from communities that are very coherent, like kibbutzim, you know, this communal type of living. So we work also with these systems too. We believe that working with the whole community is I would say, a focal point, but basically we will talk about it. We're working with what we call a concept that we coined islands of resiliency. And I would say that one of the major contributions that we would like to stress here is not that we are working with communities or with any organization and we stay as their sole resource. On the contrary, we are very much into a model of train the trainers, and by that very much looking into how to empower those that we are training and to ensure them they can train others, and by that work with what we call the cascade model. Sorry. I would say that nowadays, or I would say in the recent years, we have unfortunately had to adapt our work to the recent challenges like terrorism, immigration, global economic crisis, business continuity, the search phenomena that you're so familiar with, this numbers of people that are somehow connected to the incident, but not either not being physically injured, but they are very worried, as the American call them, the worried whale, that are flooding the medical system after an incident. And if these hospitals are not well prepared, this may block or sometimes interfere in the really important saving lives job. And also we're working with the media and also with what we call the new media, that is the social media. Yesterday, I've been in a conference where we worked with the main media in Israel, that means television and newspapers. And some of them are also the owners of some of the social medias in Israel, to talk about the impact of the way you produce or you broadcast from a tragic incident, and the terms that you're using, and the kind of photos you're taking, and the kind of people that you decide to plunge on and ask them very personal questions when they are very, very distraughted. And they will open up and tell things that many times later, they will be ashamed that everyone has seen them. And of course, we are facing the challenge that everyone in the world is challenged by, and that is the ability of anyone to be a reporter using their cell phone camera and using it on so many apps and broadcasting it without any pre-judgment of what the impact may be. And of course, we are working with the diversity of cultures, because I don't know if you know, but in Israel, we have people coming from 120 countries back to the state of Israel, and they are talking 70 languages. So I would say the very situation here is calling us to look into the diversity of cultures. However, I would say that again, recently I am the head of the Israeli Ministry of Health Committee on, I would say, novel treatment for PTSD. And we just finished a very, very big, I would say, research and search for some of the, I would say, evidence-based and partially evident methods worldwide. And it's very concerning that most of the treatments are embedded in the Western culture and Western understanding of the mind and psychology, and Western understanding of what is healing and what helps people out of crisis and trauma. Altogether, we're trying very much to do so, and some of you have been exposed to our, I would say, creative methods that, from our experience, are much more acceptable in what I call non-psychological societies or cultures. So basically, this is where we have been working in the world, because we are very active in the world. And you can see that there are so many places that we have been working, starting very early in the late 80s in Ireland. I'm sorry it's not mentioned on this map. And in recent times, we are working very extensively in Ukraine, or I should say we are working in Poland to support the Ukrainians refugees and to train Ukrainian therapists to come home and be able to train others and of course to treat people. So altogether, as you can see, we're working both inside Israel and around the world. So what is a community? Let's be a little bit more, I would say, academic. So the concept of community is defined as a number of ways in the literature for its use in various different contexts. So we, in our terms, using Maghreb and Galbraith's definitions, and we say we usually use territorial definitions. That means the area that people are inhabiting, and it relates to groups of people who share a common interest, belief, language, or culture. This is very much, I would say, an older definition of community, because nowadays so many people refers to community as their social media community. But that, of course, is a new concept that is very difficult to define, because it's not stable, and people are not committed to it, and they don't have a very important part of what we call community. Later on, I'll talk about it, is the identification with where you live. And you don't live in the internet, so well, some people do. Okay, so why community when we talk about trauma and disasters? So I think I'm not using the right one. No, yes, I'm using the right one. Hold on. No, we're not having the same. Okay, yeah, okay. It's very interesting because, you know, PTSD has a very interesting performance in the mind and presence in communities and in the mind and decision makers. It's very fluctuating. There are times that it is truly in the forefront and people are really relating it, and there are times that people are not at all interested in PTSD. Following 9/11, I think it's a very, I would say, hot subject, and people are talking all the time about PTSD. Now, talking about PTSD is basically a confusing communication, because we know that only 10% of the population, when we're talking about a general assumption of epidemiology, it's 10% of the population that will suffer from PTSD. Again, even this 10% is not correct when you're talking about various countries. For instance, in Holland, Netherlands, they're talking about 3%. And very soon we'll see that the Americans having a, I would say, flood of people that are identified with PTSD. But let's stay with 10%. So basically, the other problem is that we're not really measuring in the research PTSD, because usually we're using PTSD measurements right after the incident. And then, of course, it is not PTSD, it's either ASR or ASD, or what we call post-traumatic symptoms. And that is making a misjudgment of, sometimes they're saying 50% or more are suffering from PTSD as a result of an incident. Again, it's very interesting to say that when we're talking about natural disasters, the numbers are going down to 2 to 4% of the affected population. So this games of numbers is a very crucial thing, because Some politician will say, oh my God, the 50%. And some of them will say, oh, we can't do anything about it, it's so expensive. Or if you'll say it's only 10% or 3%, said, okay, so they will manage by themselves. So I would say the politics of PTSD is something we have to look into when we are communicating with decision makers. And very important to continuously put that across. The majority of people will recuperate on their own accord. And basically, there are studies suggesting that if you do a non-intervention versus intervention, approximately after 6 years, you will not see much of a difference between the groups when you're measuring PTSD. But if you're measuring what are the outcomes, such as depression and other anxiety-related and sometimes even personality effects, you definitely will see the change. But again, the most popular term that so many politicians and decision makers are connected with and looking into is, of course, PTSD. And another thing that we know is that sometimes exposure to trauma is basically supporting your growth, which we know from the work of Hopeful. So, and not only that, when you are doing a research and measuring in groups that have been affected by trauma and has or have PTSD, that many of them also will show a very high level of post-traumatic growth. And the question is, how come? And this is a truly perplexing, I would say, message both to professionals and to the non-professionals. So if you'll later want to ask me questions about it, I'm very open to relate to it. So if this is the case, why are we so concerned? Why are we not allowing these 10% of people maybe to receive something like personal therapy or group therapy and forget about it? Why do we involve community? Because if you look at even 10%, and let's say, I don't know what is the population in your country, but if we're talking about Israel, it's 10 million people. So 10% is 1 million people. I don't know if you have ever thought that it is possible for therapists anywhere in the world to treat this number of clientele. It's just impossible, not to mention it is costly, and it's giving a kind of sending a message to decision makers that it is something that psychologists and social workers and clinical professionals can do. And I would say, beware of that. This is false perception. We cannot. Okay, so let's look at data from USA. Recent data, and that's about the veterans coming, the soldiers coming from Afghanistan and Iraq. They are reporting 20% of the personnel reporting PTSD and, of course, major depression. They're also reporting 1.4 million of children in the USA have a parent that is actively connected to the military. So you're not only talking about the parents, but you're also talking about the kids. In 2009, which is a long time ago, already then, they said that they predict that the treatment of patients and the family for the military would cost about $12.5 billion, and it will last probably between 7 to 24 months after natural disaster. And this is a major number that we need to look into, because again, I don't see any government investing anything like it post an incident. Now, what is this graph that I'm showing you? Rodriguez, Dockery, and Woodcock did a very interesting study measuring when systems collapse following major disasters. And you won't believe it, but they looked in the past, in the history actually, on pandemics that have been in the world, but also to other natural crises. What they've shown us, and that's very important to note, that at 30%, and that's very, very concerning, because at 30% of people affected, either casualties or system personnel that is affected, the system goes into full entropy. That means chaos and dysfunctioning. And this is very concerning because if systems don't work, or I would say about 1/3, let's say even 40% of a system is not working, that means the system is almost in this study is unable to function. And so basically, they suggest that as long as we are at 10 to 15% of the system affected, we're still okay. So we should worry because of the above data and because we encountered incidents where in hindsight, we could say that the fact that these communities didn't function, and I'll give you some examples, is basically because of the collapse of the supportive system, the municipality, the mental health, the medical health, etc. Very, very disconcerting is, of course, all the study that have been following Hurricane Katrina, where they found out that in so many of the systems, medical systems, both doctors and nurses had to abandon their wards because of the flood. But that means that they were left out with very few of them, and these ones that have been that stayed behind couldn't really operate the medical systems. Same for policemen who didn't show for the job, and all of them were for two reasons. One, they were fear for their families, and so they didn't come to work. And the other side of it is that they were fearing for their lives, and that's why they left the work. But what we know is that this is really affecting the system. In Israel, during the Lebanon War of 2006, there were municipalities that both the mayor and a group, I would say a quite considerable size of community or municipality workers left the municipality, left the town with the idea that the army will take care of their population, their citizens, and they went to hotels or to more safe places. And the outcome in our study was very interesting. Less management, less staff, less effective or corporate, less cooperating and or operating municipalities. You have more people that had reported very high level of PTSD. In some of the towns, it came to the number that I showed you earlier on that I was kind of suspicious. It was about 40%, 34 to 40% of the population in these towns were the mayor and the the city professional workers have not been on site. We had the worst mental health outcome in these cities, and this is quite known phenomena nowadays. The connection between leadership and operations of local authorities and the level of suffering of their population. Most strikingly, and that's very interesting, even after colossal failure of government to act, such as in Katrina, the citizens are still looking up to the government as their primary source of support. You will hear a lot of criticism from the citizens. You will hear a lot of disappointment But still, when you ask them who should be responsible to prepare and to help you, it's the local authority. In Israel, 97% of the population following the 2006 conflict with Lebanon have seen that the government and the local authorities are the prime source of support, and 91% expect social welfare to help them, despite the fact that so many of them were abandoned by these systems and had to evacuate and go 40, 50, 60 kilometers away from the northern border. In America, we know that the question of preparedness is a great question. 30% of Americans have not prepared because they think, and I'm talking about areas of concern, areas of hurricane or of other flooding or other disasters like flooding, rain, and fires. 30% are not really making any preparation because they say the government will come to help me. And more than 60% accept to rely on emergency responders. That means they would like to think that firemen, police, medical teams will come in the first 72 hours, which is usually when these forces are very preoccupied with the most crucial places to make sure that they are functioning. Of those who perceive themselves to be prepared and said, I am prepared, 36% did not have a household plan. So they just say it as, you know, a kind of term of reference, but they don't have any substance to that declaration. 78% had not conducted a home evacuation drill, although in the United States with floods and hurricanes and all the rest of it, they many times are needing to evacuate. And so on and so forth, and 58% didn't know their community's evacuation, so they might go to the wrong direction, and that might unfortunately cause a lot of people to be injured, and of course add to the numbers of people with trauma. About 40% of the people who responded to this survey unfortunately have disabilities. Still, they have not prepared a good plan, and only few of them took action to report, to say, to connect with those who can help them in times of emergency. So this was, as I said to you in 2009, and you can see that the same happens in 2007 and so on. So it seems like people don't like to hear or talk or prepare for crisis or disasters. If you want to know the percentage, we believe that about 10 to 50% are willing to know, willing to prepare themselves. I would say accepting the government communication and instructions and directions. About 30 to 40% don't want to get involved. They are what I would say playing a blind eye, which means, no, well, we don't know if it will happen or not. And of course, some are completely, I would say about 20% are very, very worried, especially when it happens. They become hysterical because they don't know where to go, what's the information, etc. Sometimes I'm using very known fairy tales to understand this phenomenon. I'm sure you all know the story about Little Red Riding Hood. We'll come to her in a minute. But I'm sure you also may know the story about the shepherd who keeps saying, wolves, wolves, wolves. Now, why do I take this as examples? Well, first of all, I would like to say that according to these fairy tales, wolves are signs of crisis, of moments of distress and disaster. Okay? Now, let's see what happened to the community with the first kind of reaction, the wolf, the call wolf. Of course, this shepherd is calling again and again, wolf, wolf, wolf. And then they're becoming desensitized. In fact, when the real wolf appears, they don't even come to help because they are already fed up and they don't believe in the false alarms. So this group of people are, I would say, are the shepherd group are all the time on alert, but not really prepared because they are just, I would say, very, very tense and keep on being on the toes, but don't really plan anything. And they also cause the community not to be prepared. If you were in a room conference, I would ask you several questions regarding the second type of reaction, and that's of the Little Red Riding Hood. But I'll ask you the questions anyway, and you will answer it to yourself. I'll give you like half a minute to ponder, to think about it. Now, do you know how old is Little Red Riding Hood in the story? Now, you can assume there is nothing written there, but what would you assume? Well, we can just for a moment stop that and you just put up your hands when I'm asking. Those of you who think that she was 5 years old, put your arm, you know, your image of the arm, this that is appearing on my screen. Put it up if you think that she was 5. No, I don't see anyone putting. Those who think that she was 8. Those who think that she was 12. Oh yes, I can see that people are saying 8 to 12. Yes, I agree. And you know why I agree? Because you don't send a little girl to the forest to look for her grandmother or look after her grandmother if she's too young. And of course, to carry a basket needs to be a little bit stronger. Of course, it was a basket full of food. My next question to you, and again, you will put up your finger if you think yes, and you don't reply if, or you put your, do we have I don't think we have that image. You will do this one, you know, the kind of, whatever. I don't know what it is, like, anyway, you put that if you think that the question, that your answer is no. So my question is, do you think that Little Red Riding Hood knew her grandmother before she saw her in the bed? If you agree, put the hand up. I can see that Veronica thinks that. Only Veronica? I see Andrea also. Okay, and Martha. No, Martha thinks that she didn't know. All right, let me correct you, those who think that she didn't know. Would you send a 12-year-old or an 8-year-old girl to a place where she doesn't know the person? So basically, she knew her grandmother. The other thing that we know that she knew her grandmother is that the person who made her the Red Riding Hood is her mother, grandmother, sorry. So she knew the grandmother. She's not a very young girl. And my last question, do you think she knew the wolf before she met him in Granny's bed? If you do think, put up your finger like this. Do you think she knew the wolf before she met him in the grandmother's bed? Christina says no. I can see that no one thinks that, okay, Andrea thinks she did. The rest are sleeping, I believe. All right, Andrea is right. She knew the wolf because she met him on the way to her grandmother's house. She met him in the forest, not to mention that her mother said to her, avoid speaking to the wolves. Now, I'm not taking a psychoanalytical point of view, why she talked to the wolf, why she was playing with him on the way. But let's talk about what happened to her when she saw the old grandmother in the bed, which was, of course, the wolf. Because we established that she knew the grandmother. We established that she wasn't 5, she was about 8 to 12. And we established that she knew the wolf. But what she was surprised. She didn't have a plan for such a thing. And that's why she kept asking questions as if she does not believe in her own eyes, that she doesn't understand what's going on. Instead of running away, she has been frozen and she's also immobile. So what I'm actually saying that you will find in communities these two reactions, one that is hyper vigilant and very anxious, and the other one that is not really caring about what may happen, and then they got into trouble. I hope I didn't bother you with my ideas about wolves. Anyway, just to show you some statistics, I'm not going to invest much time, just to see that in these areas where there is a risk of natural disaster, just see it doesn't go beyond 50% of people having a plan, having supplies for crisis at home, etc., etc. So if we look at all these numbers, and I mentioned back the $12.5 billion of PTSD treatment, it is probably never government will be able to provide direct care for all those people. And we are only talking in the United States on veterans. I didn't talk about child abuse. I didn't talk about molestation. I didn't talk about sexual abuse, etc., etc. So if we then looking at that phenomena, I believe we must think community. Okay, so I'm not going to go into that, but that's also what is the impact of that information. Let's go to the, I would say, the incentive for your group and me to talk about community. I believe that the case of community in COVID-19 was, and still is, if we look at it, a very, I would say, important call to wake up for us psychosocial and psychological and medical professions. We realize that the numbers that have been affected, of course, directly by the virus, and I would say in the circles around it, all those who have been enclosed at home, all those that were worried about their families, all those that were, I would say, avoided or were told to avoid any social contact, I believe we now see the impact on them, and it doesn't look to disappear. It looks at the community services that could have helped were very difficult or very scarce in numbers, because they themselves also have been closed down or restricted. So what we know, and this is just a general, I would say, summary, that COVID-19 pandemic directly affected all the sectors. The global economy growth will be subjected to 1.6 decline, and in 2020, that is already confirmed. 3.2% is already confirmed, and we see now the world crisis that is not really over. The coronavirus pandemic has negatively impacted the community in many ways, and I'm just looking at very few of them. Youth work services, all those who are dealing with youth with troubles, with problems, and were not allowed to work with them, not to mention the youth were stayed at home and all the time on the screens. Shared spaces and community centers were locked down, places that we know from a lot of studies that social support is so important to maintain well-being and resilience. Those who are dealing with drugs and alcohol services have very little access, both those who are depending on that, and of course those who are rendering their help. Very difficult was to do recycling and waste. The elderly, of course, were always on the front of concern, but of course, not only because they were at risk group for the pandemic, but also because they were left alone at home. Many of them are illiterate in what we call the internet and the media in general, and felt very, very isolated. And of course, the impact on education and the impact on local economy and the impact on personal economy. So other community safety services and partnership work have also been severely scaled down. For instance, community safety issues emerged, such as poor road safety, domestic abuse, elderly abuse, mental health concerns, including mostly loneliness, isolation, depression, vulnerability, and of course, unintentional and intentional injuries such as falls, and of course, the suicide and suicide attempts that also quite rose up. So some critical points that we are trying to look into, and this is a summary that I am quoting from this study, and please let's see what we know about the positive outcomes. Very interesting that communities develop their own safety committees, safety teams, and those who came to help those who stayed at home. I mean, volunteers and people who are willing to go to assist the families, the old people, those who were suffering and needed medication, not necessarily COVID. And very interesting studies show trust in frontline staff and communities to make decisions, lifting of barriers to innovation and rapid transformation change, especially the use of the media, especially, of course, the use of internet and the communication such as Zoom. Within the community, we saw a lot of volunteering efforts, and many people stopped drinking, probably because of the need to go out, some of them because of their, drinking, that means alcohol drinking, of course. And one other, and these are just few mentions, of course, is the ability to work in flexible spaces, in flexible time. And we know that many places are still maintaining this hybrid opportunity to work, sometimes from home and sometimes in the workplace. By the way, the research shows that those who did not allow workers to come back to their workplace, at least for part of the week, the workers have suffered much more from depression, post-traumatic symptoms, and mostly loneliness. And these people somehow were the most to leave at the end of the day and look for another job because the workplace was not allowing them to meet people. The most vulnerable group was, of course, single young men and women for whom the workplace is probably one of the few, if not the only place where they can mingle and meet people. Okay, let's talk about education. UNICEF have done a major study and suggested 98.5% of the worldwide students' population was affected from the closure of education systems. And this study was carried out in 186 countries. In total, they were talking about 60% of children have learning loss, at least of one, sometimes a little bit more than 1 year. And of course, the more their families are poor and has less education, the more the kids are affected. It was also assumed that the closure of education, that was originally the assumption that it will help to stop the spread of COVID. But again, UNICEF and WHO did a research, and unfortunately, what they found out that COVID-19 actually decreased the mortality rate by 2 to 4%. That it means it was only marginally affecting, although of course every person that died is important. But what it says that the cost, the mental health cost, the social cost, the family structure cost was not taken into account, and so much was invested in making people stay home and out of contact with their natural group. So these are recommendations by international teams that have looked into the COVID-19 community, and they were suggesting critical points. One is to increase in the medium term, that means, as I would call it, within weeks to a year, an increase in referral around child neglect and abuse. We know the surge of needing children, adolescents, and of course also adults to look for individual therapy. Again, I'm not sure we can afford and we can do that, and I will go back to the concept of community in a minute. Of course, vulnerable adults and of course domestic violence that rose in high numbers during COVID needs immediate attention. Following the economic outcome, also crime increasing, they need to understand the experience of those who are seldom heard, those who are usually, as we call the silent majority. Probably there is something that we can learn from their experiences. And making the case for community safety team as partnership working, that means making sure that we are building within communities the capacity to come to help, because central governments cannot operate on that level. And that is, I think, one of the major conclusions on the immediate, and I would say, of course, on the long term, that unless community services, volunteers, and others are getting enough resources and support and training and maintenance, we may find the next global event or local incident that calls for people to stay at home or to be isolated or something like that. And even in other cases, it's very crucial to have those groups of volunteers trained and to teach them how to communicate with the ongoing services within the community. And that's probably what we call islands of resilience, which I will come to quite soon. What are the long-term priorities that this group suggested? Mental health and trauma arising from the pandemic, the impact of a deep recession on community safety issues such as crime, public services, and to ensure that the duty of public services is not rolled back on the back of amazing community voluntary efforts. That means many a times following an incident where the volunteering efforts of a community is on the rise, once the crisis is over, local services are taking the front and neglecting or sometimes even dismissing the efforts of the community instead of fortifying them, supporting them, helping them to maintain and grow and learn more and more. And of course, ensuring prevention that becomes our collective focus once again. The question of prevention on so many levels has been shown to be the most, I would say, the cheapest expenditure when we're talking about mental health. That means that prevention is reaching to many, to the thousands. Group support or intervention is getting to the, let's say, medium size. And of course, psychotherapy and personal is only going to the few. If you're looking at costing, individual therapy is the most costly effort. And of course, prevention work and information and training community people and paraprofessionals to do what we know sometimes that can help, like first aid in psychology. Psychological first aid is basically the cheapest expenditure for governments. So when we look at the impact of COVID, we can see that it has an impact on all these, I would say, diamond of partnership. That means if we talk about the social determinants of health, it affects the health and healthcare, the economic stability, which is also all of them are affecting education, neighborhood, and environments, and so on. So it's like it's one way and also interactive, and it's a very complex, I would say, structure that we need to take into consideration when we talk community following COVID. So let's go to the community as a resource. Protecting factors that has, or maybe I should stop here and ask you if you have some questions before we move there. Any questions? Not even in the chat. Okay, so we move on. All right. So this is a very, very big study that was done on 60,000 people. That means in many cases, but altogether it is accumulation of 60,000 responders. So what they actually found, that very important community resource is social embeddedness. That is the size, the activeness, the closeness of the survivors network is related strongly and consistently to his or her mental health. In simpler words, the more you have your structure, your social structure, your social support around you, or that you recreate it as soon as possible, you will have much better mental health than if you have no or very few. Another factor is perceived social support. That's very interesting because perceived social support is not a real social support. In a way, it's the belief that people will come to help me. It's the belief that I will receive this help. It's the perception that we can help ourselves. It's the perception that I trust my fellow neighbors. So it's very important. Sorry, this is the received. I will talk about the perceived in a minute. This is the received. That means the one that the thing that you're getting from your environment, the fact that people are caring for you. I misread it. The perceived is what I will talk about later. That means very important, the perceived one, because we realize that some communities that are on, I would say, logical or other criteria that would be measurement of practical things, you would think that they are very strong, but they might collapse in times of crisis. Whereas you will see a poor community suddenly rise to the occasion. And what is the difference is what we call the perceived social support. Of course, families and friends, again and again, families and friends are continuously being seen as very important for comfort and solidarity and all that. However, families are also sometimes the source of distress and conflict. So it's going two ways. Emotional information and tangible help have been again and again been seen as very important. Informational means that people get information that directs them and not information that makes them very, very upset and fearful. And of course, tangible help means that our services, of course, are being able to come to the scene and help those people. Community focused interventions for enhancing social resources are varied depending upon the crisis, the setting, and the culture. There are groups in the community that are very reluctant to receive help. I can tell you that when I worked in the United States in 9/11, following the 9/11 incident, you know, the World Trade Center, I worked in downtown Manhattan. And in this neighborhood, there was a mental health center, which they called, because of its color, the White House. Of course, it's not the White House in Washington, but it is the mental health clinic. And people refrained from going there. And despite the fact that it was kind of available, but the therapists were saying that they will only see people who will come to the center, to their clinic, and they are not going to go out of the community, which is okay. This is part of their routine. But what we found out that when we had this joint committee of school managers, of social work departments, of psychologists, and the local authorities, including the church, etc., that the condition, the type of people in the committee was anyway people who were, I would say, poor and had troubles in managing their lives. However, they didn't apply for help and they didn't come out. So we had a problem, because on the one hand, there were people who were willing to do the job. On the other hand, there were no people coming in, although in the survey, they were, I would say, reporting quite a lot of troubles. So we thought, how can we break that barrier? And we came with this idea to look for retired social workers and community workers who know that community. These are all blocks of flat, by the way, in downtown Manhattan. And interestingly, we found about 12 of them, or maybe more, I think between 12 to 18 of them. All were, of course, pensioners. They stopped working. They were formerly in the business, but they knew the community very well. And they came back after a few days and said to us, these people don't want mental health. These people need their air conditioned filters to be changed, and they don't have the money, because the what came out of the buildings, of the towers, blocked their air conditions, and they are suffocating in their flats. But the group that I have been with was mental health and social psychology and social support, and we are not dealing with buying filters for air conditions. And I said to them, I believe if you don't start this way, people will not come to any of your activities. So I convinced them. And the first thing that was done, that people that their air conditioners were completely out of no way to repair them, or that the filters were not enough. New air conditioners were bought for them. And of course, all the filters were changed. And I would say metaphorically, the fact that the filters were clear helped these people to come out and to start working in groups. They didn't want to go to the mental health because this was stigmatizing to them, but they were willing to come to groups. And our, unfortunately, major hindrance was, of course, that the mental health professionals didn't want to come out of the clinic and work within the committee, but we found volunteers, social workers, psychologists, and other good wishers who were willing to be trained how to hold support groups following such a crisis. But I told you this story because, you see, if you're not understanding the culture, or you don't understand what really bothers these people, you can have the best of program, but it won't work. There are two very important, I would say, suggestions or recommendations following a major crisis when we're talking about the idea of communities. First, keep people in their natural groups as much as possible. This is probably not referring to the pandemic, because in the pandemic, people are not mobile. But following a major crisis such as natural disaster, flooding, or even another crisis, It's very important not to disperse people, not to send them away from the community. And if that is the only solution, make sure that you are supporting the fact that families will go together, that families will stay together. That's very important. And of course, provide social activities so they won't be passive. Again, from my experience working in refugee camps in the north of Greece and in Hungary, and also in Israel, we found out that those who are, I would say, inactive or I would say passive, are slowly developing mental health problems, and sometimes even take this energy toward negative outcomes. A very interesting study was done in Israel some years ago, and they asked people what actually helps you when you're talking about your system and your community. So people were talking that the first thing that they mentioned was calling a friend or being with family or being with someone that is with them. And some were talking about praying and relying on religion. Some talked about humor, sometimes people saying avoiding the media, which keep on broadcasting the same terrible images, use of painkillers, alcohol and tobacco, not much, but still, humor, not much, unfortunately, but still. And again, very interesting, trusting the government warning. And that's very interesting that that's found to be helpful, because many people are not really following 9/11, following COVID, following other incidents, don't really trust government, but it's still interesting to find that almost 2/3 do adhering to government warning. So what we actually found out is that it is important to deal with what we call prevention. And interestingly enough, when you look at this proverb of Confucius, you really get the whole theory and practice of prevention, because it says we cannot prevent the birds of sorrow from hovering above our heads. We can only prevent them from building nests in our heads. So how do we actually build those abilities to stop troubles and the birds of sorrow from building nests in our head? And how does that connect it to what we call community resiliency? And of course, the concept of islands of resiliency that I'm talking, and countering the systemic entropy. So this is what we call the concept of islands of entropy. What we actually say that if this is the community, all these dots, if you create hubs, islands of resiliency, people, probably better as groups, who have the knowledge of the ways to communicate and contact services, who has the knowledge of what to do in times of crisis, how to calm down people, how to deal with the elderly, how to deal with the youngsters, how to support people getting involved and volunteering, etc., etc., etc. This could be a very small group of people, but once they are spread within the community and the community knows about it, they stop the entropy, which is the movement of all these small dots that actually cause chaos. So basically, they are slowing that movement. They are not making entropy go away, because unfortunately, if the system is abandoned by the decision makers and the workers, it's very difficult. But those islands of resiliency are very, very helpful to stabilize the system. And let me give you one example. So take an example of a school. Imagine that you have there about 100 teachers. You can't ask the principal to free all the 100 teachers to study how to help the kids, how to organize the class, how to organize the school, etc., etc. But you can definitely ask the principal if he can find those 10 teachers who would volunteer to be what we call islands of resilience. Now, if you look at these 10 teachers, most probably each and every one of them knows at least 5 or maybe 6 more staff. If you then have this island of resilience who affect these 6, you're already getting to 60% of the system that having some connection to how to cope and how to manage. And that's the concept of islands of resilience. Now, let's look at what is community resilience. First, we have to start with a fact. Unfortunately, communities have the potential to function effectively and adapt successfully in aftermath of disasters. Moreover, the first to respond to any disasters are normally inhabitants from the near vicinity. That is a very, very known phenomenon. And again, during COVID, at least in the beginning, this, I would say, natural support system was blocked, if not collapsed. Because we know that in disasters, for instance, those who save majority of lives are not the first responders and the rescue teams, but the local neighbors and the people who are in the vicinity, and that's for fact. So if that is the case, we need to look at other components of this idea of communities and what happened to disasters. So in disasters, family, friends, co-workers, neighbors, and strangers who happen to be in the area often conduct search and rescue activities and provide medical aid before police, fire, and other officials arrives on site. And that's again a very, very known phenomenon. And again, it is supporting the concept that we have to prepare those islands of resiliency on those volunteers within the community. However, unfortunately, helpers and officials from outside the community sometimes find it hard to accept the fact that the community has strength, resources, and abilities. In short, that the local community is resilient. Now, whenever the professionals are coming in, many a time they are either pushing away the volunteers or the emerging leadership who manage to help people because they think that they should work according to the protocols, which is true. But what the outcome is that the local people feel that no one is actually appreciate what they've done, and it makes them passive, which I said originally that is a very, very negative effect. Another thing that I would like to stress here is that when some of the communities, when outside help is coming in, and especially when there is a lot of anger toward government services or toward whoever, they don't allow outside help to come. And that, in fact, unfortunately, affect those that are very poor and very needy, because again, the main idea of crisis is that you don't have all the abilities within your community. Otherwise, it wasn't a crisis. So let's look at that. So what does it mean, community resilience? There are various ways to look at it. One thing is that we have what we call motivational versus factors, or sorry, motivational versus hygienic factors. What does it mean? Motivational are the resources that are inside people, and the hygienic external resources. This is a term that we as a team, as you can see at the bottom, found when we did a major survey in Israel, what actually people like to do and what really helps them when they are faced with crisis, and the idea to I would say cope with it. So motivational is very important. It's all the things that we have inside, or if we talk about community, all the resources we have inside. The hygienic is what we get from the outside, from government, from official services, etc. Now, what we found out when we did this survey is that awareness of threat and or the situation of distress, it takes potential motivational components that we defined in this survey, which means what will motivate your community people to take part in this process of preparedness. Awareness of threat and or situations of distress, and need or drive to function despite the prevailing situation. People wants to come and help, people wants to be part of it. Internal locus of control, that means more and more people who feel that they are able and not that they are waiting for someone from the outside to come and help. Belief in their ability to cope, what I said earlier on, its sense of capability, but it's also the belief that we are able. I mean, if you just think how President Obama was chosen, his slogan was, "Yes, we can." Prior to that, no one ever thought that America will have a black president. I'm not judging was he a good one or a bad one. Altogether, the feeling, the belief that they can do it together have made the difference. Community cohesion, unity and identity is very important to enhance the sense of belonging, the commitment and steadfastness and persistence. That is, that we really want to continue and be part of this community. It's very interesting that communities that have been severely affected by floods, natural disasters, you will see again and again that the people, when you ask them, do you want to go somewhere else? In most cases, they want to go back to where their homes were and not leave this area. So when we analyzed our questionnaires in this survey, we found that most of the activities that took place in these local authorities were in the sphere of hygienic resilience. That means we give you, the municipality, the authority says, what the people need is that we will give them, not that they will be part of. And not in the motivational sphere, that means training them, strengthening their abilities, training volunteers, respondents, being part of community committees, etc. So what we saw that when you look from the system to the community, which we call top down, the perception is we need to give them. And because we don't have enough, and this is not on our priority, we will not doing it. But when you ask the community, it's the opposite. They would like to be involved. They would like to take part. And that's very, very important. And it's very important to mention that the factors that are endangering motivational resilience also found in our survey. That's a sense of social cohesion, again, as I said, community involvement, and a sense of being impactful, that we are actually affecting our community. All right, so what actually we suggested, and as you can see, already in 1980, we created what we call a interdisciplinary comprehensive team to sit with the mayor or the person in charge of that community. So it is not only all the services that you see, for instance, police, home front, medical team, security, but also representatives of the community and of course of the psychosocial services. Because in the past, these representatives were not present in the decision makers table. And it's very important because the community and the psychology and social services point of view is very much taking into account all decisions that are made about the community. So the top down needs someone that knows the community, knows the culture, knows what's going on in the community, have done some mapping of that community, and can reflect to the team. Let me give you one example. Suppose you had, for some unfortunate reasons, many people who died. And we know that funerals are points that are very crucial. However, if the people who have been affected are from different religions, they have different needs and different rituals of bereavement and grief. And combining them is not a good idea. So again, the only one that may bring that concept and issue to the table is probably the psychosocial representative on this committee. So we basically, I would say, it's many years ago, it's 1991, that we changed the concept from local authority, comprehensive, and a responsibility. That means that the local authority is the basis for community preparedness and community coping with crisis. Okay, let's move on. And we came up with this model. So on the other, on one hand, you have the state institutes. On the other hand, you have what we call the civilian network, neighbors, third sectors, community, philanthropy, media, etc. But actually what we need is to combine that and create what we call nodes or core capacities by basically training all those partners to with very basic emergency and crisis management methods, and of course in sensitivity to the public, and also by listening to the public themselves, for instance, the neighbors and the communities, and kind of developing a system where we are all in one way or another connected. Basically, we suggested for the Israeli, I would say, system, a system whereby you will have this national meaning and solidarity, leadership and management, preparedness and learning, and defined roles and expectations from the various partners. That means both on national and local level. And what we mentioned, when it meant it to be as a, I would call it, sorry, just a second, to again, get all of them to, I would say, communicate between one another, and by that make a better resilience centers model that we are having in Israel, which is community resilience centers, where you have a collaboration between government, home front, local sectors, communities, neighborhoods, etc., all together are sitting to think about what they need for times of crisis. So basically, we're talking about guidelines for emergency campaigns that goes all the way from the local up to the national. Okay, let's move on, because I'm aware of the time. We developed a tool that we call the Community Resiliency Assessment Tool. We were very perplexed by the fact that this concept of community is so known, but there is no evidence for a good measurement that is statistically valid and was measured on site. And so we developed what we call the CRUM, the Conjoint Community Resiliency Assessment Measure. This one is translated to 16 languages, including, I think, Spanish, but I'm not sure about Catalan. But it is very important because when you're using it within the community, you will get a picture of what's the level of preparedness and resilience at that moment. And then you can also suggest to decision makers where to invest, because right now, if they have money, they usually don't ask what is the most important thing. And not only that, they don't even measure was it successful or not, because the fact that there was an activity, and we call it the halo effect, people for a moment was interested in us, is not enough. We need to be able to measure and to understand what are the components that makes a very, very cohesive community. And we came up with 5 factors. And I would start with the collective efficacy. That means I will immediately tell you each and every part. Leadership, preparedness, attachment to place, and social trust. Let's look at what it means. So leadership means, in our questionnaires, officials in my town or in my city or in my neighborhood routinely demonstrate leadership ability. Now you may ask how people know. We found out that people very much know what they feel is resiliency, or the municipal authority, regional council, or again neighborhood management in my town functions well in emergency situation. You will be surprised that people know about it, even though it's an intuitive assessment, but we found out that they do know, and leadership was found to be a crucial component of community resilience. Next is the family and community preparedness. And here, of course, the question was on practical preparation. Just like I told you in the United States and also in Israel. In my town, there are sufficient public protection facilities, such as shelters or in other places, in families and hospitals. Or in my town, there is an organization for emergency situations. And again, we found out that family and community preparedness was very important for many people when they were talking about what makes their community resilience. Next one is attachment to place. That was very interesting to note. As I told you, that people are connected and feeling part of their place. It's definitely very difficult to measure this part in big cities, but if you refer to the neighborhood, you might get a better answer. So I feel a sense of belonging to my town or to my neighborhood. The residents of my town or my neighborhood wish to continue to live together. These are examples of the questions we ask. And the social trust is the relationship between the various groups in my town are good, or other type of question is there is trust among the residents of my community or my town or my neighborhood. You can always change the term to suit the situation that you are measuring. And lastly, of course, is collective efficacy. I can depend on people in my town to come, or my city or my neighborhood to come to my assistance in crisis. Another type of question was, I believe in the ability of my community to overcome an emergency situation. That are the 5 components after doing a very, very long, and I would say kind of painstaking study on what are the components that at the end of the day predict community resilience. And that is to show you that when we measure different type of communities, they were different on the different scales. So you can see that the collective communities were very high on collective efficacy and on attachment to place, but not so much on social trust. And that also showed us there is a crisis in these communities because they were much better on collective efficacy and on attachment to place, but not on social trust. So we suggested for these communities much more work on these things and working within the committee to develop such plans. Another thing I want to show you that within time, communities can learn and be better if you prepare them. So I would say the baseline is the time of calmness, or that when this community never saw any crisis, any shelling, any mortars on them. Okay, next time they had an emergency in 2012, And this is the 2012. They got lots of help and they were better. And you can see the difference in so many items that they became better. Now, there was another calm time, and you can see that within time, people are kind of relaxed, okay? But, and that's very important to see, that when the next emergency came, they immediately stabilized themselves on collective efficacy, on leadership, on place attachment, and on social trust, and also immediately went back to a better preparedness. And that's very interesting because you see it's a long-term study on one community. One of the most important findings was that the most resilient group is the one that during COVID, we call them at-risk group, and we isolated them and we left them alone, etc., etc., etc. And that's the 66 to 75 age group. I need to tell you that this is not only in our study, it was found in many studies. And there is a reason why this group of people are the most resilient. First, most of them are retired, they have time, they have seen crisis, they have been through difficulties, they know how to cope, they have lots of skills that are not now no one is actually calling for their help. So for them, being part of a community and being active in a community is giving them a sense of meaning. However, of course, because we see them as a at-risk group, of course, we are not approaching them, not using them, and not training them. The most vulnerable group, of course, is the 26 to 35, at least in the Israeli sample, because this is a time where young families are starting to have kids and they are much more worried and they are much more into their homes and less part of or less active in the community as such. Interestingly enough, we found out that being part of community volunteer group and community preparedness group is showing an effect on your score on the CRAM, which is the measurement. You are better off than those who are not volunteering. And as a result of that, I would like to see if we have too many more. Yeah, well, I'll do that quickly because I see the time. So the first thing we talk about is to instill a social community approach in all models of intervention, following and probably better off in preparation to disasters. To assist in the creation of a professional psychosocial community team in the framework of decision-making headquarters. That means the person that I showed you, that there will be a person within the decision makers committee that is representing the psychosocial aspect. To assist in the defining and mapping of at-risk population, that means it's very easy in times of calm to map those who are in need of help in times of crisis, the elderly, the handicapped, etc. And of course, to develop responses and approaches that effectively can help them, which means to look into the possibility of creating two things. One is volunteers from the community, and the other thing is volunteers and groups of support within these families, because sometimes they are only trusting their own people, their own group, their own subgroup. Of course, to strengthen the administrations, the reciprocal relation between, as I said, the community and the management, the cooperation within the social community system and defense or economic systems, to facilitate the smooth functioning of and circumstance permitting, to assist in preservation of family, social community and organizational framework, because we know that, as I said, social cohesion is one of the most, if not the most, protective factor in all these cases. To plan for such eventualities the bulk of the responsibility should be transferred to the general population, means activate the public by giving them information, by giving them instructions, by giving them directions. Source of local assistance and knowledge should be identified and organized in advance, especially mental health, psychosocial help, and educational medical one, and basic survival skills training for the general population, either by developing apps that gives instructions and help people to manage small or medium-sized difficulties, and helping them to get ready as a family, because at the end of the day, this is the smallest group that we can help to get prepared for times of crisis. And of course, to recruit the mass media to help to strengthen the coping resources of people, because unfortunately the mass media and of course the social media is using the situation either to show how bad the situation is, how hard it is, how horrible it is, and they're using terms that are affecting people's mental health. And at the same time, I should say, to give them instructions or support or training of what helps people in times of crisis, and use, again, psychosocial experts to be part of their editorial board, or at least to assist them what to show, how to show, and mostly how to communicate with the community, so that the media will not affect more people rather than help the system to get better and reduce those who are affected. I hope I didn't use too much of your time, and I hope it is, in a way, was giving you some information, some insight into our ideas of how to work with communities. And I'm leaving the next, 20-something minutes for questions or comments.
Moltes gràcies, Molly, per aquesta interessant presentació. Iniciem, doncs, el torn de preguntes i recordem als assistents que podeu enviar-nos les vostres preguntes a través del xat al Departament de Formació del COP i les exposarem en veu alta. Moltes gràcies. Recupero una pregunta que hem rebut durant la conferència. Un segon, sisplau. Una assistent ens comentava, ens podria parlar sobre què és el fenomen de sobretensió? Gràcies.
The what? Yes. Okay. Not the surge capacity phenomena, or the model that I shared with you regarding the efficacy of communities. What was that? Can you check? Was it the entropy or was it the surge capacity?
No tenim més informació. No sé si potser la persona es pot escriure pel xat per concretar una mica més.
Yes. Yes. Okay. Okay. Now, I hope that I understood the question, so I will try to relate it. Now, I believe you all know the concept of the ripple effect. That means the fact that you have a few children in a school that have been affected is basically, let's say they've been through car accident or whatever, it's not only affecting their immediate friends and family, it affects their classes, it affects classes where their brothers and sisters are, or relatives, and it affects the teachers. So we do have what we call a ripple effect. Many times, I hope I'm answering the question, many times systems would like psychologists and psychosocial teams to relate immediately to the most painful area, which is those who were affected. It means in this case, the kids and their immediate families. But from our experience, the immediate circle is not ready to accept foreigners or strangers. They would much be better off if we support their immediate circle of support. So if I may use, again, if I understood the question correctly, but if we're talking about this circle, they would like us to be right here where the most affected people will be. However, we believe that it's better off for us to assist those around the affected ones by giving them instructions, by guiding them, by understanding from them what's going on. Are there any resources? Are there any strength and forces coming from within the family or the neighbors or the extended family? And not immediately intervene here, because we want to strengthen this circle of support. And sometimes we even will deal with that circle that is we'll work with the school, we'll work with the immediate community, we might work with the friends, all of them to be a kind of a network of support to those who are affected. We usually will recommend, and again, I'm not sure that I'm answering your question, but I'm trying to make sense of what I understood. We usually will not intervene here as much as possible, and we'll see if natural recovery processes happen here. And the question is, how long shall we wait? The question is very, very important, because we know that sometimes if you intervene too early, you might disrupt the natural course of recovery. So there are 2 or 3 things that I would say here. One is that we should see if what we call cycles are back to function. That means sleep, food, and I would say some kind of routine. If these are not happening within, let's say, 2, 3 days, 4 days, we will suggest some sort of intervention. If things are not, if things are moderate, we would like to wait at least 2 weeks, sometimes a bit more, to see if not natural network of support, natural recovery processes happens. And again, we don't abandon this circle. We come back and ask questions either to our informants, those people that we have already contacted, or directly if there is a need. So again, I'm not sure that I gave you the right answer, but this is one way to understand. And if I didn't, please clarify your question.
Moltes gràcies per la resposta. Tenim també una aportació d'un assistent que vol dir que li sembla molt interessant la conferència i que cal que les administracions en siguin conscients. I comenta també que la comunitat és una eina molt bona i que cal reforçar. Gràcies.
Okay, anyone else?
Sí, tenim més preguntes. Un moment. Un altre assistent ens comenta: aquest model es pot aplicar per problemes en una comunitat, en un barri de caire social, o només és per a catàstrofes? Gràcies.
They mean the CRAM, these 5 elements? If it is the 5 elements that I mentioned, They are used extensively in many places in the world, also in what we call calm times, when they want to plan where should the local government invest and what sort of services or training or groups they should approach or should train. And it is not necessarily for crisis, although the original request to build this measurement was done by our National Committee for Preparedness.
Moltes gràcies. Tenim una altra pregunta també al xat. Ens comenten, respecte a les franges d'edat amb major i menor nivell de vulnerabilitat, en el cas de la pandèmia, com ha estat el cas de la població infantojuvenil, atès que s'ha parlat de major vulnerabilitat en la franja d'edat dels 26 als 36 anys? Gràcies.
Yeah. Well, the study that we've done was in community, and for ethical reasons, we cannot interview the young ones, but we do have other studies that suggest that the most affected were, I would say, in general, two groups. The very young, those who were about to start schools, that means 6, 7, that actually missed the skills of being in a class, being able to stay and I would say be able to how would I say manage frustration and etc. And also to study the basics of reading, writing, mathematics, but also the social skills of being in a group. And in a group that is demanded to sit for so many hours and be recipient of information, rather than like in the kindergarten where they are still able to move. So this is the first group that I would say we found out to have quite a lot of troubles. It's not to say that the older ones between 9 and 12 are fine. The next group is, I would say, what we call junior high. The 12 to 15 that basically didn't have a lot of skills to be alone or to be independent of teachers' guidance. And at the same time, they developed the habit of being online for hours on end on the screens, and some of them developed lots of symptoms such as depression and other symptoms of anxiety. But we found out that the group that is very difficult to work with, and it's very interesting because they know the systems for a long time, they've been through school for about 10 or maybe 11 years, is the adolescents. And we believe it is to do with the fact that their concept of death and their worries as a result of COVID and their developmental stage of the need to be in their age group with their peers, and the fact that some of them really felt isolation, not only by the COVID isolation, but also by the social isolation. We saw that there was much more cyber bullying, that there was a lot of violence within this communication. And when they came back to school, they kind of, so to speak, forgot the norms of behaving in classes, and they were quite difficult to get back to the system. They somehow lost their ability to sit for more than a few minutes, because when they were on the Zoom, they sometimes just opened the Zoom, but they'd never been there. They went to sleep, or they played on the internet or on their cell phone. So altogether, they lost a lot. If I will give you our statistics, altogether, we're talking about 30% that are affected, and some of them are severely affected. What we realize, and that's very sad, that it doesn't subside with time. That means this loss of interpersonal, I would say, abilities and ability to postpone gratification, all that are still within their behavior. And one other thing we found with adolescents, that they are very worried about their family economy. They are worried that the fact that this COVID affected their family financial status is affecting their independence and their ability to continue with their, I would say, consuming type of life. And that causes a lot of conflict at home. One other thing we found is that there was lots of complaint in the at-risk adolescents group regarding abuse, sexual abuse, drug abuse, domestic violence, and in-group, between groups violence following the pandemic. And some of it happened during, but was manifested much more following. All the helplines that were working during COVID with youngsters, we're talking about those who called in, talking about loneliness, about suicidal ideation, about depression, about not getting along with parents, about the fact that they were facing the troubles in their families, especially spousal disagreement and violence. I need to say that this is, of course, a very distorted picture because it's only reported on the negative outcome of COVID. But as mental health professionals, it should worry us because it doesn't subside. And that's the most difficult thing. We hoped that within a year, 16, 18 months, it will subside. I would say that where you don't have available psychosocial and mental services available to deal with it, the situation is getting graver and graver, more difficult and more difficult. And that's the studies that we have been accumulating in the past 2.5 years.
Sí, tenim una pregunta més al xat. Ens comenten, pregunten si el que proposa és entrenar a alguns membres de la comunitat per respondre en casos d'emergència i comenta també que a Espanya tenim els membres de la protecció civil. Gràcies.
I doubt how many of the civil protection staff, how many cases they can handle, and were they not overwhelmed by the numbers during COVID and maybe in other crises. Training what we call befrienders, that means people from the community that are non-professional, some of them have some professional background but are not professionals as mental health professionals, is very important. But it's very important to teach them what we call mediating and conflict resolution, and a lot of questions about ethics, because you see from within the community to have people that are neighbors picking their nose into my trouble is a problem. So we need to train them. But again, I would say that if you have such what we call community response teams or community resiliency team, they are of a great support for the social services and of course the home front or whatever you call your services, because they know the community, they many times know the family, many times they are natural supporters within their communities. It is quite easy to locate them because people appreciate their ongoing role within the community on a voluntary basis. This is even more important when you go to what we call marginal groups or groups from another culture, where as much as you are very familiar with the tricks and methods and models, you know nothing about their habits and culture, and you might provoke more negative reaction than positive one. So I would very much encourage what we have done here in Israel, and I was also supporting such program in some places in the United States and in Japan, where these volunteers are supporting the local services when the need for someone who can mediate, who can communicate, who can calm down, because they know the norms, the culture, the people, and of course they are trained with all what we would call ethics. Because you see, in some cultures, helping someone is one thing, and keeping it as a kind of confident thing is another thing, because it's not probably within their natural norms. So that's very important for us. And if they are not trained with this helping profession, with these services, they cannot come to the scene. It has to be coordinated. They have to be on site. And most important, when the professionals are leaving the site, that they can continue the support. They know the family, for instance, bereaved family, how to help them to find food and how to accommodate whatever is going on for at least a few days after the funeral or after the disaster or crisis. So it's very important to have this network. And unfortunately, with the dissolvement or the disintegration of communities and people becoming more home-based or home-oriented, or I should say cellular phones oriented, it's getting very scarce, and that's why it's not natural anymore. These are the structures that social services, social community, and I would say in general psychosocial teams need to advocate for, because we are living in an era of loneliness, of I would say personal isolation, and people not really developing or not using a lot of their network. And once something bad happens, they are very, very lonely, and that also affects their mental situation.
Moltes gràcies. No tenim més preguntes al xat. No sé si alguna altra persona vol fer alguna aportació, enviar-nos alguna pregunta. Mentre estàs comentant que sí que estem rebent molts missatges d'agraïment per la conferència i que comenten també que ha sigut molt interessant.
I usually, when I'm face to face with a group, I usually tell a story to kind of finish off my presentation. And I wanted to know if that is possible to do today through you. Is it okay? Okay. So the story I want to tell you is in a way connected to what we talked, but it is also, I think, very important for me, because I believe that at the end of the day, we are storytelling animals. We find meaning and reason within stories. We tell stories to each other all the time. So I believe that stories are a good way to transmit a message. And I would like to tell you a story about this group of people who had lots and lots of troubles and we're very, very upset. And this community really was in big, big crisis. And in this community, there was a righteous man, a clever man, a man of spiritual abilities. And the community said to this man, you see, we knew that you always were so kind and helpful to us, but now we're in such a bad shape. Can you do something? Now, being spiritual and unusual person, he said, yes, I can. And he went out of the village. He went into the nearby forest. He lit a fire. He made kind of a prayer or some kind of ritual. And when he came back, believe it or not, it helped the community. But when he died, unfortunately, troubles continued. People have suffering. People were very upset, and they are coming now to the, I would say, students or followers of this righteous man who also knew some of the skill that he knew. And they said, oh, leaders, you need to do something. Oh, spiritual leaders, you need to go and do something for us. So they said, well, we'll try. And they went to the forest, but they forgot how to light the fire like the old man did. So they only went to the wood and they made this ritual and they made this prayer. When they came back, believe it or not, it was much better. But as you know, time passes and these people also died, but troubles are not leaving the community. Troubles are mounting and people are very upset, and they come into the successors of this group of leaders who are now in the role of leadership and are now their spiritual and community leaders. And they said, well, you know, this big man and his followers knew what to do. You go on and do something. Now, this group of descendants didn't know much about what the old man used to do, but they knew something. So they went out of the village or out of the town. They went into the forest. They didn't know much of anything, but they knew the prayer. So they made the prayer or the ritual and they came back. And again, believe it or not, it helped. And as for me, I know nothing about the forest. I know nothing about how to light the fire. I know nothing about the ritual or the prayer, but I know this story, and believe it or not, it helps. Thank you very much.
Moltes gràcies, Molly, per compartir aquesta història amb nosaltres. No tenim més preguntes al xat. En aquest cas, donaríem per tancada la sessió, però abans et cedim la paraula per si vols dir alguna paraula de tancament abans de finalitzar.
I think it's a challenge. What I talked about today, though it makes sense, is a challenge. And I would like all of us to remember that too quickly we abandoned, we left, we forgot all or a lot of all the conclusions that we came out from the COVID-19 pandemic. I am not a fortune teller, and I'm not a priest, and I'm not going to tell us that there is another tragedy coming up like COVID-19 or like any pandemic. But I think that we need to, as human beings, to embrace, learn, and use the conclusions and the understandings and the meanings that COVID-19 put across and put on the table in such a, I would say, dramatic way. And especially the fact that we cannot rely just on ourselves, and the community services of all kinds need to enlarge their capacity because the demand is so growing. And so I just urge you to at least hold a session, not only on the pathological impact of COVID, but what are the consequences and what are the things that we can do in order to make some preparations for, God forbid, something bad that may happen. And the positive outcome of creating community involvement is that many people within the community suddenly feel much better, feel much more involved, feel that some of that social cohesion is coming back to them. So even, I would say, please God, nothing bad happens. They have the outcome of being in a belonging, in a network, and being part of the big thing, which is the group or the community. So these are my final comments, and I wish you a very good night and an excellent day tomorrow.
Moltes gràcies a tu, Molly, per aquesta interessant conferència i gràcies als assistents per la vostra participació. Bona nit i us esperem a les properes activitats del COP. Moltes gràcies.
Bye-bye.